evening, everybody. I hope everybody can hear me okay there. Let's just go through what we're going to go through tonight. So we're going to be looking at sort of restorative solutions, but really going to focus more on sort of severe tooth wear. I'll talk a little bit about localized tooth wear, etc., but I just really want to look at the more severe cases this evening. And by way of an introduction, I know a lot of you who are watching will probably know me, but I'm the director of the Dominic Hassel Training Institute, which is up in Solihull. And I will just remind everybody, if anybody's interested in any of the courses that we run, if you go to dhti.co.uk, there is a load of free resources and training videos and practical videos on that website. It's all down as the evidence-based toolkit. So you can sign up for that, and there is quite a lot of tooth wear on there in terms of presentations and some occlusion, prosthose and composite work all on there. So if you're interested in any of the courses or finding out more, literally just head over there and that will tell you all about them, because I don't really want to focus on those this evening. I just want to kind of crack on with the lecture. So let's have a look. What we're going to look at today is, let's look at some cases in a bit, and we'll look at some restorative tips and some restorative solutions. But don't forget, I think the main thing to think about first of all with restorative tooth wear, what are the issues with severe tooth wear? Because really what we're treating is these issues. So essentially you're going to have inevitably vertical dimension collapse. Along with that vertical dimension collapse, you're not only going to lose the vertical component, but the patient may also have assumed this sort of pseudo class 3. Now that can be an issue in terms of when we open the bite, what sort of bite are we going to create? How are we going to create centric relation, etc. Now that's a big topic in itself, but what I'll do is direct you to a couple of articles I've written on that, which will help you with that. So we've got the actual vertical dimension collapse, which is an issue because we're going to have to open that up to get the space to restore things. The other thing to look at is we're looking at severe tooth wear now. So we've got now a severe lack of tooth structure. One of the decisions we're going to have to make is, what can we do with these teeth? Because we're going to have often multiple teeth with a questionable prognosis. What are we going to do about those? The problem is, where these plans go wrong is people start building backup teeth that were really never going to last the distance. And, you know, if things are going to be very short term, that's okay to a degree, but the patient needs to be very much aware of that in the consent process. We're also going to have multiple missing teeth often. So often the tooth wear cases are out there. The vertical dimension has collapsed. We're missing teeth. We've got questionable teeth. And as you can see with this case on the right, you also have these occlusal plane issues. You have like a roller coaster. Now, the good thing with the vertical sort of plane issues and the over-erupted teeth, as you open up the OVD, things often become a lot more simplified because you can see the case a lot more easily. Other thing that you'll often see with these tooth wear cases, the severe ones, is they're just lacking back teeth. And it's this lack of back teeth that has led to part of the problem, that all the chewing forces and the chewing is going through the front teeth. If you just, because I see this a lot with cases I'm mentoring, people just trying to fix up 3 to 3, 4 to 4, just opening the bite on these front teeth, you're really not solving the problem because they're still going to have to chew on these front teeth. So really you want to be looking at, what can we do to put this posterior support back? Inevitably that's going to generally be, it's going to be some kind of denture, or if they've got the funds, it's going to be some kind of implant solution. Occasionally bridge work, but often the teeth are so compromised they're not really up to supporting the bridge work. Other considerations, DB or SB. So are they day bruxists or day clenchers, or are they sleep bruxists? Okay. And that is really important to establish. That's going to change your whole consent process, and it's going to change the prognosis of these restorations. So I've gone through things like that in previous diagnoses of sleep bruxes and day bruxes, and I've gone through in previous presentations. So I haven't really got the time to revisit that, but it's really important that you nail that, because if those things are present, your prognosis is going to be a lot worse. Because don't forget, normal patients, they only bring their teeth together when they chew. And normal patients, really, when they're chewing, how much work are the teeth doing? Not a lot, because there's food in there. It's kind of okay saying make them a splint, etc. However, splint compliance is poor. With the newer splints, the sort of dual laminate splints, that is important, because they are much better tolerated than the soft bite guard. They're a lot cheaper and easier to fit than sort of hard Michigan type splints. So that's a big consideration. Other thing you've got to think about is funds. Implants may be out of their budget. Cobalt chromes may be out of their budget. BioClear composites, which would be your gold standard sort of composite, they may be out of their budget. So what I'm going to look at tonight is show you some cases where it's budget dentistry, not bad dentistry, just budget dentistry that brings the treatment of this tooth wear within the sort of reach of a lot more patients. Dental IQ as well is important, and that's the sort of PC word for basically, are they thick or not? Okay. Because if you're going to start doing more complex work on them, you really shouldn't be doing that unless we think they can look after it. And that sort of ties in with what you think their compliance is going to be, and can you engage them in the process? Okay. Can you get them motivated? Can you get them to maintain things? Because if their dental IQ is low, you want to keep that treatment as simple as possible. Again, a lot of these patients, not all of them, I'm seeing severe tooth wear on patients, unfortunately, in their 30s. But if they are these more elderly patients, do they have other problems? Do they have dry mouth? Do they have the dexterity to look after more complex work? All of these things are considerations. And what this will lead you to, if you consider all of these issues, is very much a treatment plan that is tailored to that patient and their particular needs and what they can look after. But also you've got to look at what they can physically afford if you're going to be providing this privately, because a lot of this really is not practical to treat on the NHS at all. And I think the next thing to look at is, well, what are the patients looking for? It's all right saying, well, we could do this, we could do that, we could do this fancy treatment. But at the end of the day, I'm more interested in sitting down and thinking, what are the patient's aspirations and what do they really want? So what's the main things patients are interested in? First of all, the main reasons I see them are basically, first of all, cosmetic. They do not like the way it looks. Don't forget, with severe tooth wear, there is the dental appearance, but as we'll look at later, I've got a nice cobalt chrome case to see you. They are looking like 10 years older, these patients, because of the vertical dimension collapse. And so for some patients, it's dental, for some patients, it's facial, and for some patients, it's a combination of the two. So that's one of the main reasons patients attend for severe tooth wear. What's the second most common reason I see? Let's skip to the bottom. It's protection. Even with severe tooth wear, they are very much, look, I don't like the way this looks. However, I can live with it, but I don't want it getting any worse. And that really changes the whole sort of ethos on what you're going to do. If they're more interested in ceramics, that's going to be for your cosmetically orientated patients. Your cobalt chromes potentially as well for them. If they're more interested about protection, you maybe think more about more simple composites, really to just try and shore things up and transfer the risk to the restorations rather than the tooth. Also functional, bizarrely, after nearly 30 years as a restorative specialist, very few patients come in and say, I can't eat. So functional's always down there as one of the big reasons why they want restoring. Often it's not. They often can get by, even with teeth like these, eating what they want and need to eat. What else is there? Obviously, sensitivity and pain. You're going to have dentine sensitivity issues with some of these patients. You're going to have pain, particularly with the severe tooth wear patients, because there may be pulpal issues because the wear is so severe and so close to the pulp. Other things they complain about, because these teeth are in such a mess and because there's missing teeth, they're having issues with general things like food packing. And so all of these are things to think about. And then finally, don't underestimate the impact it could be having on their quality of life and the psychological aspects of it. Because if they're not liking the way their teeth are looking, if they are not liking the sort of way their face is looking because everything is collapsing, this can have quite profound psychological issues on patients. And some of the nice things about restoring these patients is actually psychologically. I had one in today that I've been reviewing. She was a case that we treated with a little bit like the first case, with ceramics and with implants for the posterior support. And she's been under review now for well over for some 10, 15 years with me now, since we completed the treatment. And the psychological impact it has had on this lady is not to be underestimated. She loves smiling, and it really is psychologically beneficial for these patients. So let's have a quick think about the restorative solutions. So composites, definitely in there. Now, on the courses we teach, I'll show you some in a minute, we teach the BiClear composites. Why? Because these are long lasting, they're highly aesthetic, but to some degree they do come at a cost, but they have the real durability. Okay. I'll show you a case in a bit with what I would consider budget bulk fill composites. So they are still particle abraded, still dentine bond, but they're done very quickly to keep the cost down, but done as a bulk fill, so they're not layered. And I'll come on to this later, but what I would call the sort of blobbiest layered composites, which, we'll look at the evidence on these in a bit, but they're very short-lived composites. Now, nothing wrong with that, as long as the patient knows they're short-lived, and as long as the patient knows they're going to have to pay for them when these things fall off, etc. Ceramics would be your gold standard, and particularly with modern ceramics like Emax and zirconia, these are very, very durable. And they would be your gold standard in terms of durability and in terms of aesthetics, but the cost is higher. So you're going to have a higher cost with these in terms of monetary cost, which is going to take some of this out of the range of patients. And inevitably with ceramics, there will be more biological cost. Most of the tooth preparation is often done for ceramics. However, you're often going to need a little bit more tooth preparation to basically get rid of undercuts, etc. However, I find ceramics will give you the long-term durability. I'm looking at replacing some ceramics now that I've done 20 years ago, but they've given 20 years of service, and they're still serviceable because with the more conservative preps for Emax, zirconia, the risk tends to lie with the restoration itself. Okay. Finally, I think one of the solutions, extractions. If the tooth wear is very severe, teeth have very poor prognosis, there's OVD issues, so you can't create the space for overdentures, extractions are quite a valid option as part of the plan. And generally we're looking at partial dentures. Certainly full dentures and clearances I'm really not in favor of for these patients. They often come in requesting it, but as we all know, full dentures, particularly lower dentures, are just poor. They're a poor replacement for your natural teeth. Psychological impact is not good. What's your gold standard? Fixed implants, without a doubt. Because fixed implants will give you something durable. They will give you something close to the natural teeth in terms of aesthetics and function. But these come at a very high cost. Okay, thinking about it as well, they may not have the bone for this, but they may not have the funds. And something I'll look at more this evening is tooth supported dentures, because if we have teeth there that can't be built up, the next option is to knock them down and basically look at really using these teeth, but using them to support overdentures. So there's a lot to sort of consider with the patient here, and it's all about their aspirations cosmetically and what their budget is as well. And got to look at the costs. Ceramics, BioClears, the initial cost is high, but the long-term maintenance is low. If you're going for sort of cheaper composite techniques, then the maintenance is going to be higher, the initial cost is lower. And I'm really looking at, can the patient maintain what we're going to do with them? Okay. And particularly if they are elderly, I want to be discussing this with whoever their partner is. Potentially their children may bring them in, okay, or even their carer. I've had all of this over the last year. And it's really as important to chat to them about the treatment, because I want a sort of independent third party, if you see what I mean. Because often the children particularly are looking to do, you know, the best for their parents, but sometimes it isn't going to be the best, because it's going to be higher things that just the patient can't maintain, and the maintenance is critical. So can the patient look after it? And particularly as part of the consent process, is the patient aware of the long-term maintenance? That's got to be clear to them. Because if people have destroyed their teeth to the level, as you can see on the pictures here, maintenance is going to be high with these patients. Okay, whatever technique you use, even with ceramics, etc., there will be maintenance issues, and they need to be aware of that. And also, it's kind of quality of life issues that some of these patients, the treatment is beneficial because it will help with their quality of life. And finally, what I like to do is get the patient in, look at it all, provide a preliminary report, give them a cooling off period to have a little look through it all, and then go back through it with them. So they really, you think that they can understand this. And this is where dental IQ comes in, because if they're not understanding it, or you don't think they are understanding it, don't do it. Okay. So what's your kind of gold standard? Well, I'll cover this quickly because this isn't the main thing today. You know, here's a patient, he's lost his upper teeth due to tooth wear. He's got lower metal ceramic that is chipping and breaking. He's got teeth that are severely worn. And look at the problem, lack of posterior support as well. Look at the lower arch, lack of posterior support. And it's interesting, this is a case I treated, oh crikey, nearly 20 years ago. And he was actually in this week for some maintenance on his implants. But what would the gold standard be here? It would be rehabilitation with implants where the teeth are missing. And then with the lower incisors, replacing some of the metal ceramic. And if they're already prepped for metal ceramic, I'll use metal ceramic again, or potentially BioClear composites, or a combination of the two. And you can see here one of the problems. He's recently lost quite a lot of these upper teeth, but look at the problem, lack of posterior support again, collapse of the OVD. So this is a patient who's crying out for posterior support. Now, we can do that with dentures to some degree. If they've got the funds, implants would be my best choice, as long as they are, in terms of implants, able to maintain them, they have the bone, and, you know, particularly making sure that, you know, most of these patients, they're not periosusceptible, so peri-implantitis is less of a risk, but it's can they maintain their implants, and then Do they have bruxist habits? Because if they do, they're going to need more implants, wider implants, linked implants, etc. And so with this case, your sort of standard rehabilitation would be posterior support with implants, and then it would be restoring the upper arch with implants, and then either ceramics or metal ceramics on the lower arch. And I just thought I'd show this as an old case, because this case essentially is restored with metal ceramics at the end of the day, because he had existing metal ceramics. It's an old case, and this case nearly 20 years old. All those lower teeth are there, so he's got post crowns, he's got etc. I can testify that all of those natural teeth supported restorations still there, no problem at all, no pulpal issues, etc. And don't forget, with severe tooth wear or with tooth wear in general, pulpal issues tend to be less of a problem because the pulp has receded. His lower implants going fine. He has required some maintenance on his upper implant bridges. In terms of it, because he's a bruxist, he's a bit prone to screw loosening, and these have required maintenance over the years. And indeed, over time, on occasion, he has actually fractured one or two of the screws at the top. And his bruxism comes and goes. But even with a mouth guard, there has been maintenance on his upper work. So got to consider that. But this being your gold standard, it's expensive. Not all patients can afford numerous implants, implant bridges, etc. So it is the gold standard, but not everybody can afford it. So we've got recrowning the teeth, replacing some of the bridges, and then one or two of the teeth that were untouched in the middle, they're going to have metal ceramic as well to just match it all up. But that is still all there 20 years later. Why? Because he's got a high dental IQ and he's got caries control, because caries is the big killer with your fixed prosto. Okay, if you can't get caries control, don't think about the fixed prosto at all. And then this is why it's expensive for implant work, because there's a lot involved in it. And I'll be honest with you, if they're compromised cases, I am going screw retained metal ceramic. I know there is a big trend now for going for zirconia and going for tie bases. If there's any compromises there, do not go tie bases, because what happens with the tie bases, if the tie bases are not extended enough, the ceramic on top that's been bonded on falls off, and it literally just comes off, because I've had it happen. So I will go old school, I'll go metal ceramic, and I'll go wide platform wherever I can. But this is expensive treatment. What's your other gold standard? And this is a completely different case. This is a localized anterior tooth wear case. You can see we've got basically retained deciduous elements. The OVD needs raising. The patients had what I would call traditional composites on there. They're all chipped, they're broken, they've stained. Most of them have actually fallen off within a 5-year period, which is what we tend to find. She's got a tricky case because she's got canines where the laterals should be, but this is just a quick case to show you what we can achieve. This is going to be a BioClear case, because essentially with the BioClear cases, I would consider that to be a gold standard in terms of composite rehabilitation. Okay, so the deciduous elements, they're extracted, the implants are placed. We'll go through our normal CBCT planning, mock crown placement, etc., so we can get the angles, etc., right. You can also see another thing that I won't talk about tonight too much, but you can see we've done surgical crown lengthening. That is one of the options with more severe tooth wear. If you want to build things back up, you're going to have to look at surgical crown lengthening to gain more tooth structure. And, you know, with these cases now, don't forget, most of us have gone to scanning with the implants now. I'm trying to think. I think I've done 1 or 2 impressions for implants this year. I think one, there was a particular reason why in terms of scanning, and one time the scanner sort of packed up, so That's the only time I tend to be doing conventional impressions now for implants. It's all scanning. But look what we can do with the composites in a minute. So we've extracted the teeth, we've placed the implants, we're placing abutments on the teeth. Now, these aren't zirconia abutments, they're gold abutments with lab composite on. And now this case becomes essentially a tooth supported case, and we can build it up with BioClear composites. And why is the BioClear composite the gold standard? Because it's heated, it's monolithic, it's overbuilt, and it's wraparound. So there's no layering here, there's no kind of patting it on the incisal edge. It's a full wraparound heated shrink fit composite. Now, we teach BioClear on the courses here. I do teach stent techniques as well, but my favorite technique would be the BioClear. Gives a much better gingival contour and gingival response than stent systems. But we teach both on the courses here. So this case now becomes a relatively straightforward sort of dial composite case. And you can see here we're injecting the composite, we are overbuilding the composite, then we are cutting it back and polishing it. And that's the beauty of it. You can see with the BioClear, you get a beautiful result with it. But with the BioClear, what you get is durability. I'll show you the data on traditional composites in a bit, which is poor. It's high maintenance, it's a lot of chipping, it's low aesthetics. So really you want to be going BioClear, or you want to be going monolithic with a stent, okay? But also, if you're going to go stent technique, I think you often need to be overbuilding it or cutting things back a little bit. And if you're interested in the BioClear technique, there are a couple of composite articles on that in Dental Update from 2023 by Claire Burgess and myself. And it's Claire who runs the courses at the centre here in terms of the BioClears. And you can access all of that as well with BioClear UK as well. You can look at all the BioClear stuff there as well. So you can see that what we've done is basically wrap these round, wrap the round palatal, created a little bit of a dial effect. But if you look at the posteriors, they're only open 1 millimetre or 2. And generally these cases, they just drop into a nice bite, literally within 6 or 7 weeks in this case, because the opening is so low. So I think that would be your gold standard in terms of composite. So let's look on to the next stage. What happens if you make the decision that you can't build them back up? Why can't you build them back up? Because there just isn't enough tooth, even with crown lengthening. There are just too many teeth of questionable prognosis. There's no point building up, say, 10 teeth where 3 are really questionable and they're going to break quickly. And then you're going to have to extract them or do something with them. So what you really want to be looking at now is some of the options here, which is your overdenture option, essentially. And that can be simple acrylic, and I'll show you a case in a minute that all of you could do. And it's what I would call a budget case. We'll then look at a case where we kind of go more expensive and we go higher end treatment with higher satisfaction. That's your cobalt chrome denture. And you can start using precision crowns with that, or even precision attachments. Okay. And then finally, with the denture options, excuse me, it's whether you're going to start involving implants in a removable option. But let's look at a case. Now, I wouldn't worry about this too much, but most of the cases you're going to do are going to be overdenture cases where the denture just covers over the retained roots. That's most of the work I do. Rarely I will, as you can see with the second case, overlay the posterior teeth with the denture. Often that is done in cobalt chrome, but that's starting to become quite difficult because you've got real issues with that in terms of mucocompressibility of the tissues, etc. But I'll come on to how to get over that later. And then overlay dentures, where basically you'll have an anterior sort of flange on it, but you're often not always being able to get that because of the secondary alveolar compensation. So I wouldn't get too hung up on these sort of definitions of overdentures. But if we're going to go down the denture route, what's the benefit, as we can see on the bottom right, of keeping roots? What's the benefit? It's technically easy. You just flatten off the roots, dome them over. So it's technically easy. It's a low cost for the patient. And with these dentures, high degree of patient satisfaction. And then finally, because you've got multiple teeth which are of questionable prognosis, if these teeth fail, it's very easy just to extract them and realign the denture. So there's a good degree of serviceability. That's why I like them. More technically, you get very good denture stability. Patients can chew better and you keep the bone. Now that's important because if implants are going to be an option in the future, there's no point taking these teeth out. 10 years down the line, the patient now wants implants, but you haven't got the bone to do simple implant treatment. So do think about it. There's a lot of benefits to overdentures. And the great thing with overdentures that the studies show and that I found over the years, very high degree of patient satisfaction. If you look at the Ettinger sort of study, look at that, 94% of patients mostly or fully satisfied. Now, nobody's ever really coming to you requesting or wanting dentures, but patients do like them, okay? They're pretty satisfied with them. They tend to fulfill most of the aesthetic criteria that the patient's looking for and the functional criteria. And the Ettinger, again, another study, 2024, so that's bang up to date. And the satisfaction with these overdentures is comparable with implant-supported overdentures. Because what I see is people are too keen to like, oh, let's get all the teeth out, let's put 2 or 3 implants in and make them an implant overdenture. Well, now I would say keep the teeth. And then we can go to overdentures later, supported by implants, if we need them. Okay. So let's have a look at a case which I think all of you out there could sort of have a go at and do a good job on it. And this is a patient who sort of really just doesn't like the appearance of the teeth. And you can understand why, because they're pretty scary looking. So he's mainly concerned about the top teeth. He has, though, a limited budget. So I've gone through basically all of these treatment solutions that we talked about earlier with him. But as part of that, he's very much like, you know, you've got to be able to sit there and go, well, the implant solution is going to be 10,000, 15,000, 20,000. The cobalt chrome solution is going to be X amount. You need to be able to tell them that quite quickly so that they can look at whether they can budget for this, even with payment plans. The OVD issues, if you look back at my BDJ articles back in 2021, there's a couple in there, centric relation increasing the OVD. I talk about deprogrammers there, talk about my manual manipulation, talk about leaf gauges in two articles. And those 2 articles are kind of gone on to sort of be considered by many just to sort of be the gold standard in options for rehabilitation in terms of the OVD. So interestingly, you can see this patient, nice thing with this patient, hasn't assumed a pseudo class 3. He still has, a nice class 1 occlusion. Look at the position of the canines. What else has he got? An increasing overbite, obviously, because everything's collapsing in. Look at his occlusal plane issues. It is like a roller coaster. So what do I often do with these patients? If they're in a class 1 situation, initially you can spend literally 15-20 minutes and do it with flowable to start with. And look what I've done. Domed over the canine at the bottom, domed over the canine on the top, initially just with flowable composite, flowable bulk fill. Do that on the left, do that on the right, open the patient up. Now, if you look at the bottom right slide now, you can see that, whoa, actually, by just spending 20 minutes blobbing some composite on the canines and opening this up, the whole case becomes simple. because you can now visualize that, oh, actually, if I open him up, look, I've got space lower right to overlay that first premolar, maybe build up the second premolar. I've got space top right for denture teeth. At the front, look, if I dome over those front teeth, I've got room to actually put a denture in. And then with the lower incisors, I've got room to sort of fill those in with protective composites, not BioClears because he doesn't have the budget, just to dome them over. So just by doing that, you can take some photos, you can look at those, you can start looking at with the patient what could be achieved with this case. And literally, I'm only going to spend 20 minutes on this because my time, clinical time, as all of us is precious. But now he can have a look at this. If it looks feasible now to start doing dentures, what I'll do is particle abrade, bond, and I'll go in with bulk fill composite to build these up. And what you can do actually is a test sometimes, if you want to be sussing out whether they are bad day or night bruxis, I'll build these up and tell the patient, we're going to leave you with those for a week. You struggle to chew a little bit, but let's see, because if you knock those off this evening, we're going to know that you're a bad bruxis. If these are still here a week later, we can start thinking about treating you predictably and saving these teeth. Okay. So look again, if we look now on the bottom right again, you can just see that the case has opened up. And what I'm going to do with this case is I'm going to basically chop those top front ones down to gum level. Not going to extract them, I'm going to keep them. If we keep them, it's going to give us a better, more stable denture. And you can comfortably cut down those upper teeth with no root fillings. Generally, you'll look at that upper right one, you think, crikey, I'm going to have to root fill that to build that up. No, you're not. I do it without any local. I just cut them back until they get sensitive. And I tell the patient, look, if we keep cutting it back, it gets sensitive, you can't do anymore. We're either going to have to take it out or we're going to have to root fill it. The lower incisors, they're not his major cosmetic concern. I think there's a valid reason to just maybe take those out and make him a lower denture, but I'm trying to stay away from a lower denture. So I'm literally just going to fill in those hollows with blobs of heated composite. Okay, with blobs of heated composite. So this is the case here. So on the left, we've got the wax try-in. So look what we've done with these upper teeth. We have literally just domed them over. The canines we've built up. The two teeth on the right that could be saved have been saved. And we're going to make him a simple acrylic upper denture that is going to lie over those roots. And you look at that denture on the right and you think, crikey, that doesn't look that great. Looks okay. But you'll see when it's in the mouth and we try it in, looks fine. And more importantly, the patient likes it. But with the denture resting on these roots, you're going to get very good stability of this denture, very good comfort. And essentially, at the end of the day, you're going to get a denture that is satisfactory, liked by the patient, and can be worn by the patient. If you look at the slide on the top right, some of these lower ones we have just left. He still has molar support, and we have just domed over with composite these lowers. If you try and build them up too much, they're not going to last 5 minutes. You can't be overly ambitious with this. And let's have a look. So that's how he looks on the right with the composite. So all the 4 canines, we've just opened up the OVD on those canines. Bang, open. I've domed over those top teeth. Now, none of this is difficult. This is quite straightforward. Look at the lower incisors. We have done nothing fancy on those lower incisors because you can't see them. And then essentially these are just sort of basic rudimentary composites. Now, I think the first thing to think about with those composites is basically survival is low. Okay, so don't let people kid you that these are going to last forever. You know, one of the good systematic reviews to look at is the Ahmed one. And with the sort of composite for tooth wear, particularly for dial appliance, etc., look at the survival. 90% at 2.5 years, 50% at 5 years. So what do you warn the patient? You better be prepared for the fact some of these are going to fall off. They're going to need maintaining. You're going to have to pay for it. So I only guarantee things for a year. And I can tell you with this patient, that is about one of those pops off a year. Okay. You can particle abrade it, pop it back on. He's happy with that maintenance, but he basically is going to have to assume the cost for that. Had you crown lengthened those, built those up with BioClear, those would be going strong at 10, 15 years. But it's that initial cost is high. But if you look at the denture, it's okay. You know, it's not something I'm going to show at a cosmetic conference, but the patient's happy. It's low cost. Okay. And functionally and aesthetically, it works for the patient. Also, what's really important is now you have an OVD you can work to. So say you wanted to crown lengthen those incisors and go ceramic, you can do that. Say you wanted to crown lengthen them and you wanted to go composite, you could do BioClears on them. Say one of those incisors at the top, the pulp blows, you can extract it, reline the denture. This is nice, serviceable, you know, easy treatment to do that anybody can provide, but provides, you know, high patient satisfaction. Okay. Got to be careful though, because these root surfaces are very prone to caries. So what you've got to do is get them back with the hygienist or the therapist as much as possible and get them basically using GCMI paste in the denture, yeah, as anti-caries prevention, and applying Durafat to these root surfaces, etc., and making them aware that these do require a lot of maintenance, because that's where these things go wrong, is that things just rot underneath if you're not careful. What's the other problem with overdentures? You know, selective pressure technique is the thing, because when you take your impressions, essentially the mucosa compresses more and the denture rocks on the root surface. So this is an old slide. This is one of my cases from when I did my consultant exams with selective pressure technique. So you don't need to do this. Okay. Why don't you need to do this? Because you can just get trays with loads of holes in and something runny and put it in slowly. Or to be honest, what superseded all of this is scanning, because scanning is basically mucostatic. So what have I moved to in the practice, as a lot of us have, scanning. And let's look at it with a case here. Look, this is a case who's going to have an upper clearance, advanced perio. He's going to have lower anteriors extracted. Best of luck trying to get some impressions on that for an immediate denture. You've got no chance. You'll probably extract 3 or 4 of the teeth. Your trays are going to have to be massive because the teeth are so long. So these kind of cases, scanning has just revolutionized a lot of dentistry, but particularly overdenture and denture work. I'm a big fan of scanning because it's mucocompressive and you don't have all the problems of trying to get impressions of that. You imagine trying to get an impression of that. Teeth as long as your arm, relatively high palate. Okay, so I'll be generally using scanning for these cases. So there we go. That's it, scanned. And, you know, I'm still quite old school in some respect. It's all done with a face bow done on the DNAR, and then the dentures are made on the DNAR articulator in that position. But scanning, absolutely wonderful for these kind of cases. And this is a case who, if you look at him, he's probably never going to be suitable for implants. He's high risk perio. He's a smoker. I'm really not going to go anywhere near him with implants. Okay. So what happens if the patient's got a bit more cash? Cobalt chrome. Now, why cobalt chrome? Well, they're thinner, they fit more snugly, and because you can start adding better clasping elements, they're more secure. So the psychological benefits are better. What's the problem with cobalt chromes? They're flipping expensive. Realistically, you would not be wanting to provide large cobalt chromes for anything under £1,000 now. So that is now putting a higher cost on it. I'm more than that, but if you're going to be doing these, it's got to be £1,000. Technically, they're more difficult, but with scanning, you can go mucocompressive with them, okay, because you're just scanning, you're not compressing the tissues. And if you're going to start clasping teeth, these teeth have to be in reasonable condition, because what happens is if you start clasping teeth of poor prognosis, they fail, and then basically the whole case falls apart, because that clasp tooth that was anchoring things falls apart. So you've got to be well motivated, got to have good caries control, or don't go near the cobalt chrome. They're also more difficult to add to, particularly if you're going to start making them gingivally free to cut down plaque accumulation. But here's cobalt chrome solution, look, and look at it. He didn't have a problem with his old dentures. He's had dentures, so I didn't cut the palate out, but that is secure. You've got clasping on the molar elements. You've got tooth support now on the teeth, on the crowned teeth. And interestingly enough, I always tell patients, they're saying, oh, we're going to crown the teeth. And they're like, oh, right, well, that's ceramics. I always say to the patients, what's the best material for my crowns? I always tell them gold or metal, because it is. I know gold or metal is predictable. They never go for gold or metal these days. But he was like, no, I'll go for gold if that's all right. But look at the rest supports, look at the clasping elements. So this provides a really secure denture. And if you look at the bottom right, you can't see the gold crowns, but look at that. It's not just the tooth part of this, which is nice. It's the change in face height. And it often does make these patients look 10 years younger. It's fantastic for that. And the precision crowns, it's a little bit outside the scope of this lecture, but generally you would prepare them like you would teeth. You would have basically, singular rests on them, occlusal rest areas on them, and often a little ledge on the crown. So it has one path of insertion when it goes in. But again, this is more expensive. What are you looking at? You're looking at, £1,000 a crown, £1,000 for cobalt chrome. A lot cheaper than implant treatment, but a lot more than a simple acrylic. But it's useful to have this as your intermediate. And don't forget, you can start with the simple acrylic, and even just use it as a training denture, establish the OVD, and then move on to the cobalt chrome 2, 3, 4, 5, 6 years later. I've done it. They come back and they go, right, I want the cobalt chrome now. I want the crowns. And so you can phase the treatment for these patients, which is great. And again, look at it. It's nice. Yeah, I've gone for some simple composites on the lowers. Look, I have just filled in the incisal little edges on those for him. A lot of gold at the back. Usually I'd be doing this in zirconia, to be honest. But look at the teeth. The teeth, you can't get a flange in. And look at the domed over. They've got to be about 1 mil supragingivally, or the gum starts to grow over. But you've got to have a decent amount of space. If you don't, they start fracturing the dentures. Particularly be careful with the bruxis. They're the ones who fracture the dentures. If they're starting to fracture the just simple acrylics, the cobalt chromes tend to be more durable as well. But this is a nice intermediate solution for those patients. Okay. And often, these are called facelift dentures or something fancy like that, but they are nice to do. I like fitting these dentures because you put them in, the patient does look 10 years younger. And, they just smile when they put them in. They're comfortable, they're attentive, they're stable. Certainly they are a step up from the acrylic denture, but do bear in mind they are a step up in cost as well for the patient. And then finally, if the patient does have funds, not only can you go for these precision crowns, the final step up is you can use attachments. And, this makes me feel very old. I published back on attachments in 2001 in the European Journal of Prosto and Rest Dent. And what is the gold standard in terms of attachment? It's locators. Copings are a waste of time. Just dome over teeth. Don't put copings on them. Okay, they do nothing except increase basically the height of the tooth, and the denture is more likely to fracture, and they just kept caries around the margins. Ball attachments wear out. Magnets give you rubbish retention. I haven't used magnets in 20 years. So locators, which are often used on implants, are your gold standard. And lots of studies that show locators give much better retention than ball abutments or magnets. Okay, you know, vertical, rotational, all of these forces much better resisted by locators. And often we're using them on implants, but look, you can use these on natural teeth. So if you want to raise the game in terms of retention for your denture, you could go for locator abutments. And these are fantastic. Basically, they are stock ones that you do a cast post impression for, cement them on the tooth, okay? And then in the denture, you have your nylon clip. And these are fantastic. These dentures clip in onto these locators, and they are really, really retentive. And, you know, this is a case that one of the cases I did it with, which is a real, you know, sad case. This gentleman can't have implants. He is a smoker. He has perio. He has numerous medical conditions. He's the most unsuitable case for implants you'll ever see in your life. But he's struggling. You know, he's got this lack of lower teeth. He's struggling functionally. And we can make him, with these locators, gain a really, really nice denture. And if you can do simple cast post techniques, you can make these locators. And if you have reasonable denture skills, you can basically do locators on these patients. They are very, very simple. Okay. And I do teach this on the more comprehensive courses that we do. And these sort of dentures are life-changing for patients. Yes, there is a cost, but surprisingly, the actual cost on the locators, it's cheaper than doing basically a precision crown for the patient. Okay, so look, these simply glue into the root surfaces. You basically do the clips on to the root surface. Yeah. You then reline it into the denture. So it's simple cast post preparation. Cement the locator that's on a post. Basically put your clip over that, reline it into the denture. It's pretty much as simple as that. And for these really compromised cases, this really provides a really good solution for these patients. Okay, even if it's some kind of, unfortunately, a transitionary phase after a number of years into full dentures. But a very good alternative to extracting teeth and putting implants in and locators. Use the natural teeth first of all. Okay. So hopefully what I've given everybody there is a look at essentially the simple acrylic denture, the cobalt chrome denture, precision crowns, and also looking at things like locators, which, yes, are precision attachments, but very simple precision attachments that you don't need a lot of skill for. We've also kind of looked at the BioClear composites versus the traditional composites, but I think all of these are valid options for patients. So don't forget your simple acrylic overdenture. It's an effective low-cost option. Probably go for it with scanning, but remember that you've got to basically get plenty of fluoride on these root surfaces. And that can be a first phase in the treatment to establish the OVD, almost like a training denture. If they have funds, or in the future they can upgrade to a cobalt chrome with precision crowns, but only go for the cobalt chrome if the teeth are of reasonable prognosis and you've got good caries control, and they've also got to pay for it. Also, you can look at the use of precision attachments, but really the main precision attachment now is your locator. Very simple, quick, easy prosthodontics. If they've got the funds, look at the fixed implant option, and then either combining that with ceramics or BioClear composites, I would say, is your sort of gold standard. But remember, with the fixed implant option, particularly if they are parafunctional, you want to be getting more implants in and you want to be fixing them because they're more prone to prosthodontic complications. So thank you for your attention this evening. As I said earlier, if you're interested in any of the courses we run, the composite courses that Claire runs, the courses that I run, ceramic, implant, etc., just visit dhti.co.uk, and we've got the evidence-based toolkit there, so you can have a look at the kind of courses we run. There's lots of free material on there, so you can have a look at. So I'm happy to take questions this evening about any aspects of tooth wear or prosthodontics. So thank you for your attention tonight, and I'll await some questions in a minute. So thank you very much. Good evening. Okay, so some good questions coming in. Right, this is a good question. I'm not sure I have the answer to this. If you have a patient who is registered on the NHS, what can you do? You cannot offer privately and not on the NHS. So would that put you in breach of contract? It's tricky. I mean, the good thing is if you go for the simple acrylic option, that is often something you can do low cost, if you see what I mean. So you can go in with more simple composites. You can go in with the acrylic option. Obviously, the cobalt chrome option, that's out of their budget. Precision crowns out of their budget. But you can, because you know I have done this on the NHS many years ago, admittedly under item for fee. But you can go for the more basic denture option. Could it change your treatment planning? You may be less heroic in terms of building teeth up with composite. So you may go more for extracting teeth of poor prognosis. But yeah, I think you can offer some of this on basically on NHS patients, but they're more simple case because you can do that quite quickly. Simple acrylic denture, quick, simple composites is the answer. Yes, slightly higher maintenance needs, but I think that's a reasonable option. Okay, another question. Why is a patient not at risk of implant loss in severe tooth wear because they are especially periosusceptible? Right. Now, don't forget, most of your tooth wear patients tend not to be periosusceptible. You tend to get one or the other. I've seen both. Now, if they are periosusceptible, yeah, they are definitely prone to peri-implantitis. Don't forget, everybody's prone to peri-implantitis. I've had patients lose implants due to peri-implantitis because they haven't done the home care. Okay, they haven't picked up a TP, they haven't picked up the electric toothbrush. But yeah, generally with tooth wear, if the tooth wear is day or night bruxism, they are definitely more prone to mechanical complications with their implants. So basically screw loosening, screw fracture are the two big risks you get. So you counterbalance that by linking them and putting wider and more implants in. Okay, so that would be my kind of answer to that. Okay, another one coming in. Right, how do you ensure the canine buildups don't debond as more of it is bonded to dentine? Great question. Got to get particle abrasion. So basically what you want to be doing is getting your air abrasion unit on there. Air abrasion units, the ones we use on the courses here are the BioClear Basta would be your gold standard. Then there are cheaper units from Prestige Dental to have a look at, and cheaper units from Optident, but that ensures a much better bond. As you could see with those cases there were some hollows. So basically there was a hollow and an enamel ring. So if there is a hollow and an enamel ring, you've got a good chance. They should not debond early. If they are debonding within a week or so, that is either your bonding technique was poor or your isolation was poor, or they're a bruxist. Okay, obviously if they're debonding after 3 months or so, then there's a problem. But basically use your particle abrasion. Also, we would be using universal adhesives as well. So we use the 3M bond, which works very, very well. Okay, so hopefully that helps. BioClear. So yeah, somebody's saying that they don't have access to BioClear. Stent techniques. Now, stent techniques I do like because they are simpler than BioClear. Essentially, with the stent technique, though, you've got a cost because you've then got to have a diagnostic wax up to make your stent, and then either use heated composite or flowable. Use all the same other things. If you haven't got access to that, you're going to have to go what I would call traditional or old school composites. What you've got to accept with those is maintenance is higher, debonds higher, fractures higher. Okay, so that is just something you've got to accept. Doesn't mean, I would say, is it inferior? Yes, but it's different. As long as the patient knows the maintenance is higher, aesthetics will be lower, that's fine. And yeah, talking about the locators, yeah, bizarrely enough, the locators have been with us for years and years. I can remember when I used to examine for the Royal College of Surgeons, and I can remember students bringing these in cases with locators on natural teeth. So these are going back 15 years or so. If you go on to Zest anchors, they have all the information on them there, but they are very simple, which is why they're so brilliant. Acrylic clips that don't wear out, and then basically very easy to service, very easy to maintain. So they're really good locators, and I've been using them, oh crikey, at least 15 years on natural teeth and longer on implants. So they are very, very good. If you're using them on implants, don't forget there is the new RX locator, which is very good. Okay. Where else are we? Oh yeah, somebody's asked, could you explain the simple chairside processing? Yeah, I kind of cut those slides down because I didn't want it to be a full lecture on that, but quite simple. You would basically put the clip onto the locator abutment that's on the tooth. The denture is basically hollowed out around the clip. You put excuse me, a hard chairside reline in the denture. Then you insert the denture, and then that grips, the clip grips in the denture and on there. When you take the denture off, the clip comes out in the denture. I use a material called Takuzo. What I'll have a look at, actually, because that is a good point, I'll have a look and I'll see if the locator slides are on the evidence-based toolkit. I'm going to make a note of that. If they're not, I'll see if I can get that. There's a couple of cases where I explain those. I can probably get those up onto the website for you. Okay. Right. Now, I'm not sure I'm going to be able to answer this. Very good question from Paul. I have a patient with extensive posterior occlusive erosive wear and compensatory tooth movement. Do I gain space by a dial anteriorly and then restore the molars to normal contour and simply allow the occlusion to settle? The base, I can't really say yes or no without seeing the case, but basically, yes, you can do that. The thing you've got to be careful with is, do you need to cover those back teeth? Because I've seen dentists go wrong with this. They open things up with a dial. So the dial goes in, the bite opens, but then the posteriors have so much worn dentine, when they over erupt, they're not stable. Now, there's nothing wrong with opening it up with a dial. If you're worried about or occlusion scares you, open it up with a dial and then overlay the posteriors with composite, but leave a slight gap and then let them over erupt. What you mustn't do is basically leave severely eroded back teeth to over erupt, because they're not stable. They're just going to erode, but then you don't have the space to restore them. I hope that kind of makes sense, because I have seen that happen. So be careful with that. And I've got time just to take one more question, and it's how do you deal with patients who are a day bruxer? I don't want to be flippant, but one thing is, first of all, you tell them to stop it. The great thing with day bruxing is it tends to be things like people who drive a lot and they're clenching as soon as they get in the car. I've seen it with school teachers marking exams and they clench as soon as they do that. Great thing to make them is just a little anterior deprogrammer, or and I'm sure anterior deprogrammers are on the toolkit, just like a little anterior deprogrammer, so they're aware when they're clenching. Also, make them aware of that. Are they doing it? They often come back a week too late and go, yeah, as soon as I start doing this or that, I'm clenching. And by making them aware of it, they have a chance to stop it. But a little anterior deprogrammer, okay, and that will make them aware of it. And it doesn't have to be full coverage, because if they're just wearing it for a little bit during the day, that often works really, really well. So hopefully everybody enjoyed that. I think that's as many questions as we can take this evening. Yeah, have a look at the DHTI toolkit, and what I'll try and do is I'll try and arrange, it'll probably be next year now, I'll try and get the locator presentation on there. That shouldn't be the most difficult thing to do. So if you're interested in locators, I've got a couple of clinical cases which take you through it in a lot more detail, so I'll try and do that for you. So thank you for everybody's attention tonight, and wishing everybody a lovely Christmas. And I think I've got another presentation next year, so I'll probably have speak to some of you next year. So thanks very much, everybody, and good evening.